Welcome, everybody. My name is Alyssa Stenson from Midwest Access Project, and welcome to MAP's Introduction to Non-Scalpel Vasectomy Workshop, facilitated by Dr. Grace Shi. Super excited to have everybody here tonight. This is a personal favorite of mine, so I'm really excited for everybody to dig in with the kits that we sent, and I hope it made it safely to everybody. So welcome. This is just the description that was sent out for registration. It's going to be interactive, but feel free to have cameras off. We know this week, past week has been heavy for some, but Dr. She's going to review patient screening, some counseling, the prep, procedure techniques, and you'll have some hands-on training with the kits that you received and the medical tools. A little bit about Midwest Access Project. Our mission is to improve access to comprehensive reproductive health care by training providers in abortion, miscarriage care, contraception, pregnancy options, vasectomy, and more. Rooted in the Midwest, MAP's innovative training model fills gaps nationwide in medical education and clinical training. Feel free to check us out at our website, midwestaccessproject.org. Take care of yourself. We recognize this past week in the aftermath of the election may be heavy for some. Please take the time you need during this interactive workshop. This can maybe look like taking breaks, having your camera off, any other accessibility needs, being with your community tonight. Feel free to just show up as your authentic self. It is our collective responsibility to call out the genocide, coercive assimilation, forced sterilization, stolen land, family separation, and forced removal of Indigenous people on this land. It is not enough just to call it out. It is also important to donate money, contribute to mutual aid, and call out white supremacy. There's a list of resources that'll be sent out with your survey, so feel free to click on them and reflect. This is just an introduction, but feel free to take any notes. This is recorded and will be sent out to you all by Tuesday. But topics may be sensitive to some, so please feel free to take care of yourself and then reach out to me privately, chat or email if you have any questions or concerns about this presentation. And I will go ahead and send it over to Dr. Shi.
All right. Hi, everyone. Thank you all for coming. Truly, like Alyssa said, I know this week has just been a really heavy and challenging week. And I know each of you have just taken time and extra work to get here. So thanks for showing up for the MAP community, for your own communities, and absolutely please take care of yourself throughout this talk. What is your goal for this session? And then what do you want to take away today? That would be fantastic. Your goal of getting more comfortable with the steps of vasectomy. And then someone's thinking about bringing this into practice. So that's great. What else are people wanting to take away? This is really helpful for me at the beginning of the talk, so I can sort of lean in on the areas that are most interesting to this group. So exposure, awesome. Awesome, more about the steps of practice, how to counsel. I'm moving some people's texts around just so we can see them all. Counseling, okay, this is great. These are things that we're definitely going to cover today. Other specific takeaways people have, other than like practice integration? Awesome. So some people are, along with like sort of thinking about what it might look like in their practice, just sort of assessing like, is this something that I want to invest my time in? That's a really important question to ask. Alyssa, I don't want to click open the chat because I'm worried it will shut down again, but if there's something in there, if you can either say it or add it, that would be great. Oh, this one's getting doubled. Great counseling. Okay. All right. Well, feel free to keep adding or just thinking on these questions as we move forward. Oops, I am going to, oh no, I'm going to clear this out and we will go on to the next slide. All right, thank you all for sharing that. I think we're going to cover most, if not all of those during our talk today. And since we have such a small group, feel free to just like unmute and ask a question at any time or drop a note in the chat. And maybe Alyssa can ask chat questions as they pop up.
Yes, I will monitor the chat and let you know.
Awesome, thank you. All right, so these are the things that we're going to talk about, which align nicely with what you all want to hear. We're going to talk about vasectomy and some common questions and myths. We're going to spend quite a bit of time on the procedure itself, and you will have a chance to play with the kits that Alyssa so kindly put together for you. And then we'll talk a little bit about training at the end. This is just like a roadmap of what we'll do. I'll have a little didactic portion. It's about 20-30 minutes. And then you all will work in breakout rooms for about 10-15 minutes. And then we will have a short break just so that people can get their kits and have a bathroom break. And I have to set up a video so that you can just sort of see how to use the model a little bit better. And then we'll come back, do our hands-on stuff, and then we will have a chance for questions at the end. So jumping into it, here's just the only anatomy you really need to know in order to do a vasectomy. And so I'm curious if people are willing to shout out what they think the various parts are. Maybe I'll just name them. So starting with A, what is A?
Is that the ureter?
Yay, it's the ureter. B.
The
Wow.
bladder.
Yes, B is for bladder. C. See, sometimes people forget if it's been a long time since anatomy. That's the seminal vesicle. D.
Prostate?
Prostate. E.
Vas efferents?
Yeah. F.
Epididymis?
Yes. G is the scrotum. Sort of hard to guess on that one. And then H, the testes. So here we go. Let me clear out those names. All right. Okay. So we're going to just dive right into the procedural steps. And I think of it in sort of three big chunks. The first one is isolating the vas, and steps 1 and 2 are really the hardest because they are quite unique to the vasectomy procedure. And then so you first isolate the vas, and we'll talk about how to do that. The second is actually accessing the vas, or sort of like getting the vas within your vasectomy tools. And then 3 is vasocclusion, which we'll talk about more, is maybe the most technical aspect, but not the most procedurally challenging part of the procedure. Okay, so in terms of isolation, the way you do it is a technique called the 3-finger technique, and we will definitely practice this using the models. So if you are right-handed, you would do this with your left hand. And if you are left-handed, you would do it with your right hand. And the reason is that as your non-dominant hand is stabilizing the vas, your dominant hand has the tools. Okay, so make sure that when we're doing the practice, that's aligned with what you're doing. And what you're doing here is that you have the 3rd finger in the posterior part of the scrotum pushing upwards, while your thumb and index finger are pushing around the vas to really kind of spread the scrotal skin really thin to make it superficial. And then that way with your instruments, you're able to grab just the vas. And with a vasectomy, what you do is you make one opening and the midline. And so you use the 3-finger technique also to manipulate the vas right in between the scrotum. So in terms of accessing the vas, you guys all have these tools with you in your kits. There are 2 main tools that are like sort of vasectomy specific. So the first one is that ringed clamp. And this is what you're going to loop the vas with. So, you know, you have this one, I know my thing is blurry, but you loop the vas with the small ring forceps. And then essentially the dissecting forceps are just really sharp curved hemostats, and that's what you'll do to dissect the fascia around the vas deferens. So an important thing to know as someone who's doing vasectomies is just the data around no scalpel vasectomy versus incisional vasectomy. When I was first learning about vasectomy, I was like, what's like a no scalpel vasectomy? Like, how do you even like enter the scrotum if you don't have a scalpel? So that's where that really sharp curved hemostat comes in. And when they developed this technique in the late 90s, there were quite a few studies comparing like a scalpel versus a non-scalpel vasectomy. And this is sort of the Sentinel article on it. It was an RCT that was done with, you know, 1,429 folks in it. And what they really found is that, especially in terms of bleeding and hematoma, there was far less when you use the no scalpel, that sharp dissecting hemostat. And when you think about it, it sort of makes sense, because with that 3-finger technique, right, if you picture the vas is very superficial, and then you loop the vas with that ring clamp, you've really targeted the area where you're going to do your procedure. And then you use that the dissecting hemostat just to go over the skin, right over the vas where you're going to do all of your occlusion methods. So it makes sense that there's going to be a lot less bleeding and fewer hematomas than if you just kind of do a larger opening with a scalpel. So the AUA, which is the American Urological Association, and we'll talk about their recs more during the talk, they really do recommend the no scalpel approach to a vasectomy. So then thinking about occlusion techniques, I have a couple of different diagrams on this because I think this one is nice because it's in color and has a little bit more, I think it's easier to understand. But then the AUA actually uses this like pictorial technical drawing, which we'll also show you. But in terms of occlusion, so occlusion techniques are really just talking about how do you get the sperm prevent the sperm from traveling in the vas deferens, right? So you can do a bunch of different things, and people combine these in all sorts of ways, but basically there are a couple of options. So one is cautery. So this is just like thermal cautery, and you can cauterize one end or both ends of the vas deferens. You can also excise a piece of the vas deferens. This one I abbreviate as fascial int, stands for fascial interposition. And I often describe this as sort of burying one end of the vas. And you can actually see it really nicely in this third drawing here, where you can see there's like one end and then the fascia is pulled over it and then they've ligated it over. This is essentially the same thing they're doing on this side here. This side has been cauterized. That's why it's like a little bit darker here. And then they've done it fascial interposition here. So this is a different combination, again, ligation with fascial interposition. Here's one where they've done cautery and fascial interposition. They've done it with a clip instead of sutures, and they've also excised a piece of the vas. And then this is ligation and excision. So those are the options. And then this I wanted to walk through just because if you do end up doing a vasectomy, or you want like a one place reference for vasectomy questions, the one I really recommend is the AUA vasectomy guidelines. I think they're actually working on updating them this year, but I think they're like 2020 is maybe the most recent version. And they have this diagram in here, so it's nice to just know what they're talking about. So I'm going to walk that through with you all. So again, here are the different types of occlusive methods that we talked about: fascial interposition, cautery, they always refer to like either the testicular end or the abdominal end. And then this is the Marie Stopes technique, which I'll show you here. So the way you read this diagram here is like you have your vas deferens, and then you've got the testicular end and the abdominal end. This little dotted line means that they did some sort of fascial interposition. The dark means that it's been cauterized. So in this particular example, what they've done is they've left the testicular end open, and then they've done cautery and fascial interposition to the abdominal end. In this one, the Marie Stopes, they essentially just cauterize a longer segment of the vas, 2 to 3 centimeters. Sorry, my vas tube is in the bar. Okay. In this one, you have ligation on both ends. And then here are a bunch of other ways folks can do it. So mucosal cautery with fascial interposition, without fascial interposition, ligation, and or clips. So I would love to hear from folks, which occlusion techniques do they think have the highest success rates or lowest failure rates? And I labeled them in green, A, B, C, D, E, F, G.
Somebody in the chat said A.
Okay.
Somebody said D.
A and D, great. For those of you who have maybe seen a vasectomy before, if you're able to like maybe remember or pick out which technique the vasectomist used. Okay, so somebody wrote in anything with cautery and interposition. Okay. So that would be like A, B, and D. Or maybe not B, that's just cautery. All right. Well, you guys did great. So the AUA recommends the 4 occlusion techniques that I put in red. So A, B, D, and E. And I'm going to show you what the actual failure rates are of all of them. So you can see that even the ones that are not recommended, you know, they could theoretically have quite low failure rates, but the range is quite high. And so it sort of depends on maybe the technique of the proceduralist. And then, but in these recommended ones, they are quite low, less than around 0.5% on the high end of things. And so what I often like point out as a takeaway is that cautery is really important. And then you might not have to do fascial interposition if you sort of cauterize both ends. One thing that I was talking to a colleague about is that with this particular technique, the Marie Stopes one that does just cautery, the cautery is quite long. So 2 to 3 centimeters is quite long. Usually like a cautery tip is less than 1 centimeter. And so you're probably trying to get a little bit more length on each side of the cautery that you are doing. Questions about this piece? All right. So again, you will, if you go work with lots of vasectomists, you'll probably see a lot of people doing different things and different combinations of the stuff that we just talked about. But these are the 4 that the AUA recommends. And I'll say in my practice, I usually do A. And actually I wanted to address, oftentimes people will ask a question about this open end, like why do we have an open-ended vasectomy? And so the reason this technique was sort of developed was that there's very rare reports of folks who have a vasectomy where they feel afterwards like a sort of like a fullness or testicular fullness or congestion. And there was a thought that when you either like ligate or cauterize or somehow occlude the testicular end, so remember that's the part that's still connected to the epididymis, that maybe it's making it harder for the sperm that is continuing to be created to be reabsorbed, and that's what is creating the fullness. And so folks did some studies around like leaving the testicular end open, But what they found actually is because that congestive, post-vasectomy congestive syndrome is really, really quite rare. They just didn't have any cases when they did it, but they found that the efficacy of the vasectomy itself didn't change when you left the testicular end open. And so that's why I continue to do it, because, you know, if it helps with comfort, I definitely want to keep doing that. And especially since the efficacy rate is so high. So that's what's going on with that technique. All right, and then I want to show a video of vasectomy being done. Let me pull it up really quickly. And we can pause the video at any time to just talk about what you all are seeing. Let me make sure.
And so I'm starting the anesthesia.
Can y'all hear
Yes,
that?
we can hear and see.
Okay, I'm gonna make it bigger. And then also, in my talk, I didn't talk much about the block, but we'll show it here. So this is gonna be a paravasal block, and it's usually 0.5 to 1% lidocaine with no epi, not buffered. And I usually draw up 10 cc's in my syringe, but I don't usually use all of it. I probably use on average 5 to 6 cc's, and then I save the rest for like additional if the patient is uncomfortable. And essentially you use that same 3-finger technique, the isolation of the vas, and you just try to get the anesthesia as close to the vas as possible. So you'll see that here.
Right now, I'm getting the vas in my fingers. So my bottom fingers is just acting as a sort of a hook to bring the vas right there. What is important is I'm putting my right finger on my middle finger of the other, not my middle finger of the other end. So if I raise my thumb, the vas stays there. Otherwise it goes. So I need to play with those 3 fingers to put the vas exactly where I want on the median raphe. So I'm going to start. Bougez pas, ça va.
Is getting the vas
yeah,
the hardest part?
Yeah, it's one of the hardest parts. So I'm just putting about 0.5 cc on the skin, very, very superficial, and then I'm getting directly to the vas. And when my needle is actually, now I can see my needle is right on the vas because I cannot push anything. Trying to push a little harder. So I'm very, very near the vas.
And I just want to say a couple things. One is that the patient is quite comfortable during this procedure. And this is probably the most uncomfortable part. I don't think Dr. LeBrick said, but he uses quite a small gauge needle around like 30 or 32. And it is recommended that you use the smallest needle that you can in order to give the anesthesia. And then he, I think, slips into French a couple of times. So I like to let people know. So he's a family physician in Quebec. He really specializes in vasectomy. He's one of the authors in the AUA guidelines, and he's based in Quebec. So I think sometimes he speaks in French.
I'm going to put about 0.5 cc's. So you don't want to, when you do that, you don't want to poke in and out, so to avoid little vessels. So in one movement, so that's done. And I'm gonna, whoops. Yeah, just put your head in front. Okay. Yeah.
Well, just light it.
Yeah, yeah. So I'm gonna, my hook is there. I'm gonna push my hand like this. So when I get it, I get to
And you can see like he's basically trying to find the same place, like this is his wheel where he's already numb superficially. So the second side should be less uncomfortable, but the second side, the vas itself has not been anesthetized. So this is what he's going to do.
And then you see my finger here is very important. So I can really well locate and position the vas. Then I'm going to introduce my needle in the earlier site. Just go to the vas and inject about 0.5 cc's again on this vas.
Does the size of the vas affect your quantity or?
No. No, it's about always the same. So I keep about half a cc just in case I have to top up the anesthesia. So once 1 cc and a half total is enough. You'll see the patient shouldn't feel anything. So now I'm starting to get the vas again. So I'm starting on the left side.
Does it matter?
Yeah, it doesn't matter. Some people prefer to go on the right. I prefer to go on the left because my opening will be right in front of me when
Okay, so just wanted to show you like
I'll go.
how when you see in your kits the ring clamp, it's like so tiny, right? So he spends a little bit of time just adjusting that clamp so it is just around the vas, and this is where you can see why the no scalpel versus the incisional is going to be so much more directed and have less bleeding.
I'll go back to the second side. So I put this in the ring forceps, and then I'm going to pierce the skin. So it's important that the tool is very sharp, so you can sharpen it, and you introduce both. And then when
and I want to point this out to you because when we get to the model, this is a place where the model is not particularly high fidelity. So like it actually feels quite real in the 3-finger technique, and but when you start to dissect your kits, what is going to happen is the elasticity of the rubber is going to make it spring back together, and that happens a little bit with the scrotal skin. But just watch here; it doesn't totally close; it sort of stays open a little bit.
get the tip into the vas, the superficial layer of the vas, I just open.
When he pulled back, you can still sort of see the vas under there. Just note that when we use our model, it'll be a little different.
So I was not deep enough, so I'll just pierce it again.
So he's dissecting through the fascial layers.
Right into the vas. Now you can see the opening here. I'll introduce my instrument inside, and I'll just push down the fascia so I'll make sure.
And then once you actually have the vas fully dissected, you'll see when he lifts this instrument up, the fascia usually falls to the side.
It's all bared vas.
And it just kind of slips out.
Here, I'll just put my instrument, my ring forceps, under and above, and I get it. Now, the no scalpel.
You flipped over your hand.
And then one other thing, I'm going to just show that again.
Forceps, under and.
There's a vessel here, and I always, when I'm training or when I'm doing a vasectomy myself, when I'm pulling it out, I always see like, do I know where this vessel is? Because this is the one I want to avoid. It's often on this side laterally, but sometimes also medial. So just look on either side of the
Above, and I get it. Now, the no scalpel.
You flipped over your hand?
Yeah.
Oops.
I'll just. Okay. Now I'll just finalize the no scalpel approach. So
and all he's doing there is pushing that fascia down, which also makes that blood vessel go farther away from the vas.
just made a little opening. There's a little drop of blood here, but that's no problem. It will.
In this, the way he opens, so in order to do the cautery, obviously you have to be able to get your cautery instrument into the lumen, and so he's just clipping it like halfway so that he can access the lumen.
I will just when I do the facial deposition, I will just put that in the clip. So I do my little mucosal cautery.
What are you doing?
Cut the vas. I'm cutting the vas now.
And so that end that he just cauterized and cut off, right? That's the abdominal end, and then this one that he's still holding is the testicular end.
And you see the vas just went into the fascia. And you see the little bleeder here. I'll just make sure that it's in the it's in my clip, and you can see the vas right there. And I'll just put my clip very tight, so you can see I've got a little ridge here making sure that all the fascia is in there, the vas is in there, The bleeder is controlled with the clip. That's it.
And
All right, I'm just gonna show this last part one more time.
The vase is in there.
So this does look like our diagram, right? Where we have our abdominal end is buried under this fascia. This is like your little, there's a clip holding that shut. This is just some leftover fascia on the end, other end. This is your testicular end that's left open. There's nothing that has been done with that other than just cut on this end. There's no cautery or anything to this end. And then sometimes people will ask about excision. If you remember when that occlusive technique, some people do excision and some people don't. It's actually recommended that you don't do excision. And I think the theoretical reason, well, the reason is that it's an extra step. It doesn't add anything to your efficacy. But I have read some theories that if you actually cut your excision end to here, then you're actually like decreasing the length by which if a sperm were to come out here to find this other end. So right now you have like length on your side as well.
The bleeder is controlled with the clip. That's it.
and why do you use clips versus silk?
Because in our practice, I think it's faster. I would say probably silk or other material would be, or even Vicryl would be fine. I know some other colleagues, they're using catgut.
All right, so he's just gonna do the other side and he'll actually access it from the same opening. So I like to pause here just because usually there are some questions about this. Let me,
Yeah, I have a question.
yeah.
So after he incised the skin, what did he do to take the vas out?
Okay, so you loop the vase first with that ringed instrument, and then you dissect the skin over the top of it, and then you sort of like flip the vase out. I'm going to show you that part of the video and see if that makes sense to you. Okay, this is still block.
The patient shouldn't feel anything right in front of me when
Okay, so this
I'll
is
go, I'll go back to the
looping the
second
vase
side.
part.
So I put this in the
So this is just getting the
in the
skin
ring forceps, and then
dissected
I'm gonna
over the
pierce
vase.
the skin. So it's important that the tool is very sharp, so you can sharpen and you introduce both.
So again, you like
And
open
then
the scrotal skin, and then you'll
when I
start to
get
see
the tip into the vase,
the fascia and or the vas,
superficial layer of
just
the vase,
depending
I
on the
just open.
anatomy.
We can see
But the vas has a very like a shiny pearly color to it.
here that there is still a layer, so I was not deep enough. So I'll just
So he's just saying there that he can sort of see the vas behind another fascial layer. So he wants to get below that fascial layer before he can really flip or deliver the vas out.
pierce it again
So
and just go
getting under that
right
fascial
into
layer.
the
So then
vase.
now he's seen the
Now
vas.
you
So
can
this
see
is the part you're talking about. So what he'll do here is he'll take one blade of the dissecting hemostat and put it into the lumen of the vas itself.
Opening here,
And then we'll flip it out.
I'll
So
introduce my
when you flip,
instrument inside,
so then you're kind of like pushing the vas out of the sheath.
and I'll
And this
just
is he like uses his thumb to push some of that sheath down to make it come out even easier.
push down the fascia, so I'll make sure.
So it doesn't
It's
create a
all-
hole in the vas to do that.
It does. You kind of poke a little hole in the vas.
No, but
Yeah.
like it doesn't like just tear through the vas when you try to pick it up with
Oh,
the.
yes, it doesn't, because the vas is actually, if you have your model close, this is where I think the fidelity of the model is really quite good, is it feels really like that inner tube, which is just a Penrose drain, has a very similar texture, and I have gotten quite forceful sometimes making that little opening, and it's really quite difficult to totally rip the vas. Like you could, but you would probably in your 3-finger isolation realize like, oh, I can tell this is sort of a thin vas. It's like not as I don't know what the right word is, like bouncy or firm. as that Penrose drain, and you would be like, okay, I'm not going to push so hard when I do that.
Scared
Yeah.
fast.
So then
And you
you'll
can
see, so it's like he's just holding it by a little bit of the hemostat and it kind of slips out. And again, just to compare this to the model, because it's so rubbery, the slipping out part really is not replicated in your model.
see here, I'll just put my instrument, my ring forceps under.
All right, other questions?
I have a question.
Yeah.
Is the instrument that we have, uh, is this as sharp as the one that he's using, or we're gonna expect like something more sharp when we're doing the dissection?
Um, so maybe I'll say I'm not sure. I know I didn't get a new kit this year because we did do this workshop last year and I got a kit then, so I didn't get another one. But if we use the same vendor as a last year's kit and they're the same, it's similar sharpness. So like you could just take your dissecting forceps and like it should feel pointy, like not as quite as pointy as a needle maybe, but close. So
Okay.
maybe you can, is that what you got?
Yes, 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 yes. Yeah, I was wondering if it has to be like kind of like very pointy as a needle or something, because I see that he gets into the skin very easily.
Yeah, I mean, it does have to be pretty sharp. Like it shouldn't be blunt, like just regular hemostats. So if it's blunt like that, that's not going to work, but it should look and feel pretty pointy.
Okay.
Other questions? These are great questions. Keep them coming. Because I know this group was really interested in the procedural steps, so I would love to get those questions. Yeah.
From the we looked at earlier, like options A through E, and you were like A, B, and D were the most effective. This looks like it's the clip. So was that C that he's doing?
I don't remember. It could be A, but using clip instead of suture. Because I know
Oh.
he's doing the way I do it, but I don't use clips, I use suture.
Okay.
So I don't know if they separately diagrammed that. And the efficacy between clip and suture is there's no difference. Like you can do fascial interposition however you want to. And it's funny that the patient asks like, oh, why are you using clips instead of suture? I've asked him that myself and he's just like, he runs a vasectomy practice and it is longer to do it with sutures. And he like did all this math and was like, look, Grace, if I do it with clips, I save this much time. Other questions? All right, well, as they come up, please feel free to drop them in the chat or just ask them. And then we'll go on to counseling now. Oops. Okay. All right, so first step is just to make sure your patient is comfortable and encourage them to ask questions. I usually just start off by giving them a rundown of my counseling visit, and after I tell them like, I'm gonna I want to make sure all of your questions are answered. We'll talk a little bit about your past medical history, and at the end, I'll do an exam just to make sure that it's safe for us to proceed with the procedure. And then I just jump in with like, what questions you have coming in, because if they have one right away, I want to like get that off their mind so that they can sort of like listen and engage throughout the conversation. And then, like I said, I get some background information, including their past medical history. Like, what are the things that are coming to mind that are particularly important to get for a vasectomy procedure in terms of their past medical history?
Any scrotal trauma?
Scrotal trauma, yeah, scrotal trauma, scrotal procedures. What
Bleeding
else?
disorders.
Bleeding disorders, yeah, anything that might make them more likely to bleed is really important. What else?
Any history of radiation to the pelvis?
Oh, tell me more about the concern for radiation.
Well, that could just change how the tissues behave.
Yeah. So, like it might make them more, friable is not the right word, but, that's the one that's coming to mind. Easier to tear, I guess is what I'm sort of thinking about. Yeah, so you guys, hit the major things. I didn't say specifically when, you all said scrotal trauma, but just thinking about other like anatomical, right? If they have a history of a hydrocele or varicocele, neither of those are, contraindications, but you would want to know, especially before your exam, so you can just see if like, okay, is the hydrocele in the way or the varicocele is in the way, then maybe, doing a no scalpel, version is not going to be as effective. All right, and then the other big part is just, emphasizing that it is a permanent procedure. And so I often say to my patients, like, well, first I say that it is a permanent procedure. And then sometimes I say, like, sometimes people will ask me about reversal because they've heard like a friend or cousin or, somebody has gotten it reversed. But we really think about it as a permanent procedure because reversal is not, guaranteed to be successful, and it's not, covered by insurance. So we really want our patients to be, prepared for that before they get their vasectomy. So these are some the questions that I ask. I particularly like the first one, just because I think it gets people talking. Some of my colleagues say like, oh, what are the reasons you want to get a vasectomy? And I worry that that makes it seem like they have to justify their decision to you. And so I think I've had a lot of success with just saying like, oh, how long have you been thinking about a vasectomy? And they'll say, oh, I've been thinking about it for like, I often get like multiple years actually is probably the most common answer that I get. And then they say like, oh yeah, and then this happened, I couldn't get around to this and that. And then you get a sense of like, okay, you know, it is what's either just these are some things that might make increase the risk of regret. And in terms of regret, it's about the same as with tubal sterilization. These are the same sort of risk factors for regret. And ultimately these are the patients, it's their lives and their decision. And even if they are young or, in an unstable relationship, these aren't reasons to not do a vasectomy, but there are reasons to just help your patient think about, like, is this the right time for this decision for them? So then in terms of actually describing to the procedure to patients, I really have found it useful to just have a visual aid. I have like a laminated, it's actually the picture that we did the review of anatomy on, but it doesn't have the labels of the parts. It's just that diagram, and I have it laminated in my office, and then I have like a white marker that I write over it as I'm explaining. And so usually what I do with counseling is I say like, okay, this is what's happening in your body prior to doing a vasectomy. And so for all of my patients, I also sort of ask them like, I want to use the words that you're familiar with. Are there any like terms that you do or don't want me to use as I'm doing this description? And then I use their vocabulary to describe. And what I say is that like sperm matures in the epididymis, and then it travels through the vas deferens and out the urethra. And then I say, okay, so then during the vasectomy, what we're going to do is a couple of things to stop the movement of the sperm. Let me just, oh yeah, sorry. So I use this diagram, but it doesn't have things labeled. And then I use my marker and I say, okay, so the first thing we're going to do is we'll actually cut the vas, and I just put a little line here. And then I say the second thing I'm going to do is I'm going to cauterize the vasectomy vas, and I draw like a black marker over the vas here. And then the third thing I do is something called fascial interposition, and that's where I bury part of the vas under some tissue, and I kind of just like draw a half circle here. So then what happens after the vasectomy is that because nothing has changed for the epididymis or the testes, your body will continue to make sperm. So the sperm will continue to be made, and then it will get here where I've made the mark, but there's nowhere for it to go. And then when you do ejaculate, which a lot of the ejaculatory fluid is actually contribution from the seminal vesicle and the prostate, there just won't be any sperm in the ejaculate. So that's how I usually describe the procedure itself. It's also nice because one of the important things for them to know is that they need to have a post-vasectomy semen analysis to confirm success. And so I also use the diagram to say, like, you know, you need the PVSA, and that is because there's sperm, and I just kind of put dots all along the vas and here. There's sperm that's trapped along this tract that all need to leave or die before the vasectomy is can be relied on for contraception. Questions about counseling or other things that you've heard providers do that you would like to share?
I'm curious if you counsel in like an office visit or if it's the procedure visit itself.
So you can do it in both ways. So it actually partly depends on insurance. So federally, in order for any permanent sterilization like tubules or vasectomies, if you're using public insurance, you need at least 30 days between the counseling visit and the procedure visit. So this is like a paternalistic relic that we still have. So if it's public insurance, it's a separate visit. If it's private insurance, at least in Washington State, the private insurances that we have you can do it on the same day. Does that answer your question?
Yeah, thank you.
Yeah. Other questions about counseling?
Quick question. What's the expected recovery in time frame?
Yes, I have a slide. Let me we talked about that. Oh, okay. I think it's one of the small group cases. So we will get to that, I promise. And if we don't, we'll circle back to it. Other questions? Okay, I want to make sure. Oh, go ahead.
Sorry, I'm just curious, for the people who have to have 30 days between counseling and the procedure, what's your show rate for the procedure?
Good question. It's pretty good. The caveat I have to that is that I have excellent support staff and they usually call folks ahead of time. So I don't know what it would be if there wasn't that support.
Thank you.
Yeah. It is definitely another barrier. What I wouldn't say often, because again, I have excellent support staff, but occasionally we'll get someone who's like, oh, I didn't know that I needed to do this 30 day, like they just didn't know they needed the counseling visit and we didn't catch it. And I would say that happens not every time I do, I mean, it happens enough that it's like, oh gosh, why do we have this extra barrier? All right, would somebody from group one just walk us through your discussion and your answers here?
Sure. So we have this patient, a 45-year-old, who's coming for a vasectomy. He has some questions regarding what would be the impact of the vasectomy on the following. Libido, we said no change on the libido. Testosterone, no change. Sexual frequency, no change, but we need to wait 12 weeks, or the patient needs to be like at least 12 weeks on backup protection and then have a sperm check at that time. Erection, no change. Ejaculation, no change, but to be noted that there will be no sperms. And sexual satisfaction, it can potentially increase.
So thank you for sharing that. All of those answers are correct. I think sometimes if your patient has a lot of questions about sexual functions where that diagram can be really helpful. And I often will like emphasize, okay, testosterone is from the testes and we're not going to do anything to the testes. Or like, I also emphasize that like the penis is totally out of the way of the procedure. And we don't do anything to the penis if patients are particularly concerned about any of those things. And then the sexual satisfaction is true. And sometimes I will share that, yeah, there's some studies show that there's like increase in sexual satisfaction. That is not from the vasectomy itself. It's from like the not having the burden of unplanned pregnancy that makes it more enjoyable. Did your group get to the second one?
We were just
We
actually
barely-
discussing
we barely
that
had
part.
time to look at it. We did look
Yeah.
at the article. I think the article is from 2014, and as far as I can tell, it looks like there's been some follow-up studies that have. So the article seems to, from this 2014 study that seems to look at men who had vasectomy and men who didn't, and that the men who had vasectomy had a higher rate of aggressive prostate cancers. We didn't really have a chance to look at that carefully, but it does look like there's been subsequent studies to say that have been included larger groups of people, one in the New England Journal of Medicine, and another one that was a follow-up study at the same institution, to show that was done like 6 years later, that showed that they didn't have an increase. They had a lower rate of prostate cancer. So
Yeah. Okay.
so it seems like there's mixed messages, and it'd be interesting to see, like, I didn't get to look at this article carefully enough to understand like why they came to that conclusion. Or
Yeah, you all did amazing for the very short amount of time. And those are the appropriate takeaways. I'll just add a couple of things. So that article is the clipping I sent is quite old, but it's this actual worry comes up in the last 15 years. I want to say every like 5 years, there's some like small study that shows some sort of association, and people go and reanalyze it. The high level takeaway is actually that I would say like the AUA actually does look at this like in each of their iterations. And when they really do like a systematic review of the articles available, there really is not an increase of prostate cancer with vasectomy. And there's a couple of, the one particular one, that article that this one links to, has a couple of errors, both in how they detected. So one of the things is that it really had a high possibility detection bias. Mostly because those who get a vasectomy are ones who have seen a provider, right? Who are more likely to get, say, a PSA or a prostate exam. And so there is more of a detection bias. And then the other big issue with this particular study was it was based on, I believe, partner report of prostate cancer. So not like a medical record diagnosis of prostate cancer. And so like often patient report of especially like BPH versus prostate cancer can be a little bit confounding. So their outcome was not really well defined. But I think the overarching one is really that in subsequent studies, and when they really try to systematically look at this particular question, there is no relationship between vasectomy and prostate cancer. And in those guidelines that I referred to, they really specifically say it is not, they don't recommend routinely discussing this during your counseling. Of course, if your patient brings it up, you can talk about it, but they recommend against like routine counseling about it because there's just no association. We're gonna move to group 2. What did y'all get?
So for the first question, we have a 38-year-old with one child interested in vasectomy, a concern for post-procedure complications, and the most common ones that we found were swelling, bruising, infection, bleeding, and pain.
Yep, absolutely. And all of those, even cumulatively, are like less than 2%. So it's quite rare to have any of those complications. And then did you all have a chance to discuss like post-procedure care? Actually, for this one, I might show, let me just show, I have a slide on post-care since this was something that you all asked earlier. So in terms of post-vasectomy care, this is generally what we recommend is like using some sort of scrotal support, like a jock strap or tight underwear for at least 2 days after the vasectomy. And then ice or frozen peas on and off to minimize swelling. The swelling is the thing that's going to make folks feel the most uncomfortable after a vasectomy. So the scrotal support, the ice, and also just like bed rest. Those are the things that are going to keep them the most comfortable. And I often will explain or describe like post vasectomy care as in sort of like short term as the next 2 to 3 days. And then I say long term is sort of the week, because I want them to be like really low activity 2 to 3 days, not quite like bed rest, but like low activity. And then a week is like no heavy lifting. And here I really ask my patients like, okay, I tell people not to do anything strenuous in the first week. Like, what's on your mind? Because I've gotten answers like, I had a patient who was like, I'm going to go to a jiu-jitsu tournament. And I was like, okay, I don't recommend that. Like, but, so I say that blanket statement, then I say like, what are the activities that are coming to mind that you're concerned about, and try to like help them figure that out. And then I don't routinely prescribe anything for pain medications. Usually Tylenol or ibuprofen is sufficient. And I just tell them that like, if they're doing all of these things, they're resting, they're doing ice, and they have on scrotal support, and they took Tylenol and they're still really uncomfortable, I just want to hear from them. Like, maybe the answer is trying more or different pain medications, but maybe something else is going on, and I just want them to call. And I get very few phone calls actually. So, all right. And then the last group.
Yeah, that was mine. Oh, sorry. I thought you meant the last question.
Sorry, last question. Okay, go for it. Sorry, I forgot there was a
Oh,
Go for it.
I basically wrote all the things that I found down there. But yeah, the most common like scrotal nodule like complications / differential that I found were sperm granuloma, hematoma, and then less commonly like a neuroma or a congestive epididymitis. For sperm granuloma, it's just supportive care. Hematoma, they like probably should be, I mean, all of these they probably should be seen, but hematoma may require like operative evacuation, so maybe a little more serious. The neuroma, it was kind of hard to find like exactly how to treat that, but I read like these alcohol sclerosing injections for that. And then I guess congestive epididymitis, like antibiotics is what I read for that, and also supportive care. I don't
Awesome.
know if
Thank
there
you.
were other nodules.
Yeah, those are great. I'll just add, so with the sperm granuloma, essentially this is an inflammatory reaction, often after like, essentially with like, for example, with an open-ended, and you have the sperm like leaking out of the open end, like you can have an inflammatory reaction at that end. And usually it will actually just get better over a couple of weeks. And the typical presentation is actually like patients doing great a couple weeks after vasectomy, and then like 2 to 3 weeks later, they're like, I noticed like a tender spot, and like they feel like a little bit of a nodule, because it takes a while for that inflammatory response to like show itself. So if you can have them take NSAIDs regularly for another couple of weeks after that, then it usually goes away on its own. Hematomas for sure, like that is what I would say is the most common thing I see, but not to the level of surgical evacuation, like more to the level of like, I had a patient once play soccer with their kiddo, even though I talked to them about that, and the kiddo was like 5 or something, and kicked the ball like right into his groin, and then he had a bleeder and got a big bruise. And most of the time, even like a big scrotal hematoma, like I would say any sort of hematoma like is probably pretty common, but that's from like a pea-sized hematoma to like a half of like a ping pong ball, or no, that's too big. a small hematoma, it could be fairly common. Even those like say ping pong ball hematomas, those will actually resolve on their own. The ones that are very large, those are the ones that might need evacuation. The scrotal neuroma, I actually don't know what an alcohol sclerosing injection is. However, I have had colleagues treat those with like steroid injections and have quite good success. So that would certainly be an option. And then epididymitis, I think we talked about a little bit, but for sure, like antibiotics and supportive care. Awesome. Okay, group 3. I will make it bigger so you can see your whole table in a minute.
Hi there. So we divided up the questions because we were short on time. So what I found was from the Guttmacher Institute, they said they had 2018 numbers for, it was like 28% using, so sorry, it's 36% using a permanent form, either vasectomy or tubal, and then 28% use the tubal. So I figured, I just subtracted, I figured 8%.
Yeah, that
It
works.
seems like a really low number. I was surprised it was that low.
No, that's about right. The range is usually 6 to 8, so that's right in there.
Wow.
All right.
All right. And then considerations about the timing. So what I found was that for men, if they do it before, if they have a vasectomy when they're younger than 30, they're more likely to regret it and want to have it reversed. Not sure how accurate that is. But also they said, when you're not new to parenting, so if you have a screaming infant at home, it's probably not a good time to get a vasectomy. And the anesthesia is the local that we talked about. I forget what the bottom question was there. Oh, follow-up. And then the PVSA, I think, is the only necessary follow-up. And then for tubals, a really good time to do it is after a vaginal delivery or with a C-section, but you don't have to do it related to pregnancy. And one thing I found was that doing it right after your period, you're just less likely to have an egg that's already been released and circulating. And it's usually done with spinal anesthesia.
Awesome. All right. And the only thing I was just going to say in terms of timing, it was more to contrast vasectomy with tubal in terms of the timing, like whether it's a postpartum tubal or an interval tubal.
Okay.
Not specific timing considerations for vasectomy, although it's interesting you brought up like having a screaming. I have so many patients that just had a newborn that are getting a vasectomy. All right. And then the last one.
I mean, yeah, women do it all the time, but I guess they said that what I found.
And then complications. I think we talked about that a little bit. So maybe
I put a article in the chat that I found from 2020, and it was more of a summary article that had a really good table with the complications. And they do address what we were talking about earlier about like no increased risk of prostate cancer, change in sex hormones. And then I left the tubal more broad, just 'cause I didn't have time, but also I think it can vary a lot. But I think that the general takeaway for me was that tubals have more major complication possibilities. I would say like surrounding organ damage and needing full like anesthesia. It's a surgery, and I consider vasectomy to be a procedure. And then the failure rate, I think it really depends on the technique. I know we talked about that before, but there is a much wider range, whereas for tubal, it's less. The data I found was less than 1%, but that was off of the Planned Parenthood website. So, yeah.
Yeah, that's great. So yeah, absolutely. That's the important takeaway from tubal versus vasectomy in terms of the complications. They both have, minor complication rates, but in terms of major ones, there's almost none for vasectomy, and there's more for tubals just because of the anesthesia and like the operative demand. And then in terms of failure rate, it is true if you look at all of the techniques of vasectomy, the range is wider. However, like if you just look at those recommended techniques, they're overall lower than female sterilization. Although I will say when I'm counseling folks on vasectomy, I don't specifically say like one is more effective than their other, because honestly, they're both just very effective. And so helping them think through, more of the other risks or their other concerns, I think often is kind of where they want to talk more. And then in cost, I'll just say this is approximate.
Sorry.
Oh, yep.
I wasn't able to add to the doc just because I wasn't able to access it.
Oh, okay.
But basically, it looks like tubals are significantly more expensive than vasectomies, depending on your insurance and what state you live in. There are at least 9 states that require insurance to cover vasectomies completely. And so it can cost anywhere between 0 to close to $2,000 if you're paying cash, cash pay. And if you are, and then on average, people, even with insurance, pay between 231 to like 250 to basically $450 ish on average, depending on how much insurance or how good your insurance is, versus a tubal, which on average costs between $5,000 and $6,000 after insurance, because it's a surgical procedure. But if it's laparoscopic, it can cost anywhere between like $6,000 to $14,000, at least in 2020. And then if it's non-laparoscopic, it's cheaper, and that's anywhere between like 3,500 and about 7,000. So on average, it can cost about $6,000.
Yeah, awesome. Thank you so much. You all did such an amazing job, and I gave you like no time. So I'm very impressed with you all. Because we're pressed for time, we're gonna like, maybe if you need to take a break, please just do it. But I'm gonna just set up the camera and stuff live so that we don't have to take another break right now. So go ahead and grab your kits, and then we're gonna walk through how to use them for practice. So, you'll see, I'm going to mute myself so I don't get a weird echo. Okay, you can still.
Yeah, your camera's showing up now.
Okay, can you hear me?
Yes.
Can you hear me?
No feedback.
Okay, what about now?
No feedback.
Excellent. Okay. So. All right, so. Okay, so you guys should have your instruments, both instruments here, and your scrotum. Can people maybe just do like a thumbs up if they're ready? I don't want to start if people are still getting their stuff. Or you can turn your video on. Okay, cool. Some people are here. Yay, most people here. Okay, awesome. So again, there's going to be a couple of parts that are a little bit frustrating with this model, but we'll just get through it. The hardest part of the vasectomy is actually the isolation and grabbing of the vas, which this model is actually good at. So that's why it's worth it to have this. So what I first want you to put your instruments just to the side for the moment. And let me just orient you to this. So obviously this is a resistance band. The resistance band is the scrotal skin. And then if you look inside, you actually have, they're not stapled on both ends because we want to make them a little floppy because that's how they are in the scrotum. You have a 2 tubes, this like harder one, the Penrose is the blah, 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 is the vas, and then this is the fascia. So the first thing I want you to do after you re-put your vas back in is do your 3-finger technique. Remember, if you're right-handed, you're going to use your left hand with it. And you start by putting your thumb on the top and your middle finger in the back, and your index finger is sort of out of the way. Let me do it like that. And you start midline and you kind of drag your hand until you feel the tube, and then you clamp down on it and you use the second finger to spread it out. And you should be able to see in this model like a nice indentation of where the vase is. Your
Is it possible just to turn your camera 90 degrees so it, yeah. Okay, thank you.
oh, sorry, this way. Okay. So again, just starting over, I'm just going to hold the scrotum still here, but your middle finger is in the back and your thumb is on the top. And you sort of imagine the medium raphe is somewhere here. So you kind of start around the medium raphe. I'm pushing my first and third finger together and I'm dragging it along the scrotum until I feel the vase, and then I clamp down on it pretty hard. So I go from something kind of relaxed to hard. And then I take this second finger and I spread the scrotal skin tight so that I can really see this bump. And I also actually, even now, I started doing this when I was learning, but I just find it helpful. I'll take my other finger, my dominant hand's index finger, and I drag it along and then I think, oh yes, that is definitely the vase. And I get used to it's like, some people say al dente pasta. I think that is accurate. I also think this feels very accurate. There's like a bounciness to the vase that is unique to the vase. So like just getting this right, your dominant hand, like used to that little bouncy feeling to make sure, yep, I have the vase. Okay. Are people at this stage, give me like a thumbs up if you're here. Great. Cool. So now you can grab your ring. So this tool. And then what you're going to do is you're actually going to hold it palms up. And this is just to get like more direct pressure. You want to go perpendicular on it. And so what I often do is I'll drag this over the top again, just feeling, yes, this is the vase. And then if you open slowly over the top of your vase while pushing down, it's going to like slip down around your vase. And then you can just grab it. So for practicing later, I would say that that set of things that we just did is something you want to do on this model like as many times as you can. 3-finger isolation, getting used to this hand position, and then getting used to grabbing it with this with the ring forcep. The rest of it, for sure you can do, but this model we'll walk through it so you know what to expect. But the model, because the rubbers are so sticky to each other, makes the procedure harder than it actually is in real life, and is more of the things like if you do any sort of like lac repair that you'll be more used to, so it won't be such a learning curve. So then from this, you're going to move your hand out of the 3-finger position, and you kind of like hold like this. So the instrument is still resting on your non-dominant hand, and then your dominant hand is going to get the dissecting. So then this is where you're going to take one blade to make your pierce. So you pierce right over the top of the vase, put one in. Then this is where the rubber is going to come right back together. It's going to be hard to see where you put the hole, but try to get it back into that same hole and then spread. And you should start to see, like you can see the white of the tube popping out. That's your vase. That's absolutely what you want. And again, this is where the model is going to be a little more frustrating, but I'm going to show you a way to make it a little less frustrating. I'm going to pull it out and it's going to close right back up. But what you can do for the model, if you pull and stretch it again, like really stretch it, you can it'll retain that little opening, which obviously you don't have to do this in the real life. But then you keep dissecting, and then you can really start to see the vase there. Oops, sorry, there's the camera there. So there's my vase right there. If you can get to this point, that's great. The other thing you can practice and you have to modify is to do the flip. So in order to practice doing the flip, you actually have to pull this vase out a little bit manually. So I pulled it out like that, and then you pierce it, clamp, and then you flip while releasing this one. And sometimes this doesn't quite work like just now. It's so sticky, it won't do it, but that is sort of the motion. And then that's the last step before the cautery and stuff. So how are people doing? Where are people getting caught up in this?
So I think I made a hole. I think I can get my instrument into the hole, but then I can't figure out what I'm supposed to do next with it. Like
Okay.
I got a
So-
hole bigger. I got the hole bigger, I think. Oh, I see. My instrument's not all the way in there. Okay.
So it sounds like you made your
I got a
hole.
hole, and then, but I think I haven't broken the fascia yet, right?
Oh, okay.
So I
So
got
what I
the
think-
yellow, but not through the fascia.
Okay, so what I think you should do for this particular model is after you made your hole like this and you pulled out and now the hole's like very tiny, you can't see it, try stretching it so that you can, so it retains, so you can see at least the
Oh, stretch
fascia.
the yellow part.
Huh?
Oh,
Yeah, stretch the yellow part.
Oh, I see.
And
Okay,
then
that makes
keep,
sense.
so that you still see a little bit of it, and then you can practice the getting below into the fascia.
Okay, thank you. And then I just do the
Yeah.
same thing over again with the,
It's hard. It's hard for it to keep that shape. So if you really want to practice the flip, I recommend once you really see your vase, you see how I'm closing around the vase,
Mhm.
and then I'm sort of like, I'm trying to just yank it out. You might even unhook this to yank it out of the fascia. Like, so it's almost like this, but you can still, now I have the vase is right there. So you can still practice the flip by piercing it and then rotating your hand upwards. And then you can do the grab that here. And then that's really in terms of like the technical aspect of the vase, that those are all the key pieces. The rest is like cautery and cutting. Other people stuck in different places or having successes? Gonna release this again. I will tell you, so when I was learning vase, I actually used a model like this. This is the same thing, but with cloth and cotton batting inside. But it only had the tube and no fascia. But it was so helpful for me to just get used to dragging my hand and getting into a 3-finger technique and just doing this over and over just so that I was comfortable with those hand positions. Because again, what will happen, what makes this a little bit trickier in real life is that the vase is going to slip around. So like you'll do your 3-finger, you'll be dragging, you'll be like, yay, I have it. You've clamped down on it. You have a nice grab, but then as soon as you get this instrument on and you put pressure on it, it like flagoing goes somewhere else. So you have to do this over and over. The like 3-finger technique, you have to like grab and re-grab a lot, especially at the beginning. But even as you get more experience, the vase continue to slip. So you need to really get used to this. So often, like I said, I take my instrument and I drag it over the top. Part of the reason I do that is if I can't even drag it over the top without putting pressure on it and it slips, I wasn't holding it tight enough. And I'd rather not put all the energy into trying to grab it if it's going to slip right away. So I drag it over the top. I make sure I know where it is. I make sure that the grab's pretty good and it's not going to move. Then I go for it and grab it.
I'm still having a lot of trouble getting the fascia. What I'm doing wrong.
Doing what with the fascia?
Trying to get to the vase through the fascia.
So in that same spot that you were at. So
Yeah.
even by like stretching the scrotal skin. When you
Well,
stretch the scrotal skin, do you still retain can you still see the fascia or is it?
Yeah, I can see the fascia. I even made a hole in the fascia. I'm just,
Mhm.
it's not lined up perfectly. Maybe that's my lack of knowing where to put the hole.
It might
Mhm.
not be lined up perfectly. The other thing that can happen is sometimes people make like such a tiny little opening in the rubber that it's actually really, really hard. So you could try making a bigger opening.
Okay. Thank you.
What about other people? How's it going?
I have a question. Once you have cauterized the abdominal end,
Mm-hmm.
that automatically will split, right? The vasa into the testicle and the abdominal portion, right? With the
No, not necessarily. No. So usually, so the way I do it is a little bit, so what we showed in the video is once he has the vas out, let me see if I can, well, okay, once he has the vas out, he, I'm gonna just pretend that this is not the scrotum, but if the vas is here instead, so he cuts like a little, cuts it in half so that he can get the pen inside.
Mhm.
And so it's still connected on the other end. The cautery will not,
Cut.
make that opening, but then afterwards he cuts it. So I do it very slightly differently, but I use the cautery I just make like a little dot hole over the top. So then I have opening to the lumen. I put it in, and then I like to use scissors to cut across. He used cautery to cut across at the end. Either way is fine. I just like um, using scissors makes like a cleaner cut, which then when I'm doing my fascial interposition, I think it's neater, but it doesn't really matter. So then I cauterize and then I cut the vas itself, and then that abdominal end goes underneath, and I suture up the fascia. Does that
Okay.
make sense?
Yes. And how do you do the
Yeah.
fascial interposition? Because
Yeah, so
again,
you can't do that on this model because that would require like cutting the tube. But essentially, in the video, what you do is like once the tube is cut, it actually sort of naturally retracts into the fascia. So then you just take the fascia it's going into and you like scrunch it up and then either suture or clip it. That's why in that video when you showed the clip, there was like a little bundle of fascia over the top, like that's just the fascia that it sort of lives in.
Oh, I see.
Yeah.
Okay.
I have a question
Okay.
about the anesthesia.
Yeah.
So where are you just putting it into the tissue around the vas, or are you actually putting it into the vas?
Yeah, great question. You are putting it alongside the vase. We're gonna pretend this pencil is the vase. So you're gonna essentially, I need like another pencil. So if this is the vase, like you're holding it, right? And this is gonna be my syringe. So I am sort of imagining putting it right alongside the vase. If you put it into the lumen, it's fine, but the lumen is actually really like dense. And then like it'll get a lot of resistance. You won't be able to put it in. But for a paravasal block, you're just trying to get as close as you can into the vase. So I always tell like my residents, just like try to trace along the side of the vase as best as you can. If you get some into the lumen, it's no big deal, but you're just trying to get right along. So like tracking right along the vase here. Does that
And
answer your question?
yeah, I guess. And are there sensory nerves traveling along the vas that you're targeting, or?
Yeah,
I'm
they're just
confused by the
like,
paravasal block.
say again?
I'm just confused, I guess, by the term paravasal block. Like what
Oh,
exactly are we blocking?
yeah, so it's not like there's like one specific nerve plexus necessarily that you're trying to get to, but like the vas has like a bunch of peripheral nerves around it. So what you're trying to do is like you do your 3-finger block wherever you think you can get your vas, and then you're putting the anesthesia proximal to that in this area to just basically like do a local block. Does that there's not like a plexus that you're aiming for, if that's what you're asking.
Okay, yeah, that's helpful.
Oh, okay. So I have a question. So not you don't anesthesiate necessarily the location that you are gonna exactly get in. So you are anesthesiating the part that it's a little bit more proximal.
Yeah, so you're gonna, so like say this is where you anticipate actually like grabbing, let's say you anticipate grabbing here. You're
Mhm.
gonna do you're gonna do a superficial, like as you're doing your block, like in the video, remember there's like that little wheel that he made. So I'm gonna make a
Mhm.
little wheel right here, like a little one. You don't want to make it too big of a bleb because remember, this instrument is tiny. If you make a really big bleb, you're gonna make it really hard to get everything in here. So
Yeah.
I have a tiny bleb here and then I advance it farther. I probably advance it 3/4 of a centimeter to probably about here, and then I give the bulk of my anesthesia here.
I see. Thank you.
Yeah. Other questions? Was everyone at least able to do this part again, which is the part I think to practice over and over with this model is 3-finger block, trap, spread, and a grab. Can you people give me a thumbs up if they were at least able to do that? The part with the fascia is less accurate and more difficult. So good. Okay, it looks like most people were able to at least do that part. Awesome. Okay, thank you all for staying over. I really appreciate it. I love the enthusiasm and the questions. I wanted to share one last thing about training. Oh, shoot.
I have just one last question. When you close,
Why is this happening?
do you close a skin with just a simple stitch?
You fixed the problem.
Okay, can you guys hear me?
Yes.
Okay,
Yes.
I just got
And
rid of
someone
my.
had a question as well. I think it was Alejandro had a question.
Okay, I think I heard it. It was, do we close with a simple stitch? No, I leave it open and most people do as well because the opening on the scrotum ends up being about 4 millimeters. It's quite tiny. And so it doesn't really need a stitch. And then the other thing is that the scrotal skin is like really redundant. So like it sort of ends up folding up on itself. And heals really well on its own. In my mind, I always think like if I put a stitch there, I think it's going to be more uncomfortable and then people might like itch it or something. So I just let it be. If for some reason, if it's a difficult vasectomy and you end up needing to like convert to like and make a bigger opening, you could, but I have yet to need to put a stitch over the top.
Have you ever
Other-
tried stir strips?
No, I haven't tried steri strips. I mean, you could do that too. I mean, mostly it's just because it's such a small opening and it heals well on its own that I feel like less is more in this scenario, but you wouldn't be wrong if you wanted to do that.
Okay, thank you.
Yeah. Other questions? All right, so I just have like last thing on some training opportunities. It's really hard to get training on vasectomy, in my opinion, like far too hard. So I just have a couple of suggestions. In terms of like hands-on training, I really think your best shots are local. I put Planned Parenthood, but what I should really put is like local sexual and reproductive health clinics. Just because if you're in an area where they need providers and you're interested in committed to training, that's going to be your best luck rather than like trying to find some place outside of your community to get you to train. Because there's in that sense, like finding vasectomy hubs is really, really difficult. So the people that I have seen successfully get trained is they're like, oh, I was talking to so-and-so who is in my city and they do vasectomies, but they'd like to take a vacation sometime. And I said I would learn to train, and they trained me. So that's where I would really look the most and where I've seen the most encouraging things. But other than that, there are a couple of places that I don't necessarily endorse, but will share for you just to have it as a resource. So one is NSVI, No Scalpel Vasectomy International. They go on some medical mission trips and they do vasectomies. If you go to their website and you click on interested vasectomists, it will list their upcoming trips, and there is a cost to those trips because usually you pay your own airfare, and then you make a donation to the organization, which is a nice organization that really tries to dispel myths around vasectomies and educate communities about vasectomy. And then there are a couple places within the US that do some training. So the one is Doug Stein, who is a urologist. He's based in Florida, and you can get trained by him. In my notes somewhere, I had put how much his training costs. Oh, here it is. Okay. He charges $350 per training case. The patients get a discount on these vasectomies, and he usually guarantees around 8 to 10 cases over 2 to 3 days. So that is an option. And then Charles Monteith, who is an OBGYN in North Carolina, has a similar training program, but he will only train those who are in the US and are not residents or already in a training program. And then he really wants to train folks who already have sort of a pathway to doing vasectomy. On his website, he says something like they have to commit to performing at least 10 vasectomies per week after their training. So basically, if you're going to join a vasectomy practice, but you need more training, that he would be happy to help train you. And then the last thing is not a hands-on resource. However, it is a really good general research. The top one, the Vasectomy Network Google group. I actually run this with Doug Stein and Michelle Lebrecq, who was in the video. But it's just a Google group, for those of you who are on Access Listserv, it's sort of like that, except it's specific to vasectomy. So that's a great place to just post questions that you have about vasectomy, or the folks who were looking to start a vasectomy, integrate it into their practice. There's often questions about how to do PVSA, or just logistical questions about that. That could also be a place where maybe if you're looking for hands-on opportunities in your local area, you could post there and see if anybody is willing to have a learner. So that's a resource that's free. And if anybody wants to join that Google group, you can just email me directly. I'll put my email in right now, and I can add you to the listserv. Actually, sorry, don't do that one. That's my UW one. Do my Gmail, please. All right, and then somebody asked, how many cases until you felt comfortable doing these independently? So that's always the $1 million question for any procedure, I feel like. And obviously the answer is really wide. People ask me that so much that I actually did a very informal survey on our Google group a year ago. So I'll tell you personally, around 30 is where I felt okay, I'm getting close. And then around 50 is maybe where I felt confident doing them independently. And when I surveyed the group, actually, a lot of people said they felt competent and ready to go around 10. So I think there's a range.